This is a case of hip rigidity in an athlete from oblique ilium upslip, which I will explain. I'm Jerry Hesch with the Hesch Institute, which is near Las Vegas, Nevada, in Henderson, Nevada, and our website is www.heschinstitute.com. We do consultation and treatment for complex injuries, and we also teach seminars and distance learning to hands-on clinicians. Steve, could you lie on your back and describe your primary problem?
I came in with discomfort when I run. In particular, it tends to trigger it, but then it stays with me. I get a tightness, and it just feels like one of my legs has spring and works, and the other one up in the hip and lower back area just feels very stiff and as if it's locked and has no spring at all. Sometimes I do various exercises, and the exercises will relieve temporarily, but it almost always comes back, and most importantly, it's getting to the point where if I continue to run, then there's several days of penalty in doing that.
What do you mean penalty?
Meaning that it takes several days of stretching and exercises and yoga to try and get it so that it'll function again. So obviously I reach the point where it's, is it even worth running when I'm looking forward to a 5-day recovery period afterwards?
Yeah, and your wife is quite the runner too, so I'm sure she wants you to keep up with her, right?
Hard to do, but yes.
Yeah, she's quite the athlete. What describe her competition?
She just loves to run more than anything, and she's done many marathons, and she's done a 50-miler, and currently she's training for a 100-miler. And she's very small and compact, and you see her, and she just looks like this girl's going to run forever. And she when she did her 50-miler, the next day she was ready to run again. She had no recovery.
That's remarkable. So we did a look at your hip motion, and your hip motion is pretty good in all directions. A little bit of stiffness. It's a little bit less mobility than the other hip, but nothing that really screams at me. And I wasn't able to provoke any real pain. But what really got my attention was, and I'll demonstrate that when you lie on your stomach shortly, but your hip really has pretty good mobility in every direction, but you do have some inhibition. Here, show us how strong you are. Hold that leg up.
Oh.
Don't let me push it down, and it's not strong. Do this one, please. Hold it up. Don't let me push it down. Hold it. Hold it, hold it, hold it. See? A lot stronger there. So we have some inhibition in the hip flexors, but what really caught my attention is the rigidity when I try to push your pelvis into what I call side glide. And that just doesn't move, trying to push the pelvis to the left. When I come over to the left side and I try to make the pelvis side glide from the left to the right, I can push to an end point, I can spring it, and it goes a little bit more. Okay? Let's have you lie on your stomach. There's many lessons in your presentation. Your hip extension is decent. Your hip rotation is not very dissimilar from the other side. A little tighter in external rotation. That's about 25 degrees. And in internal rotation, it's about 30. But each of those have a normative spring at the end of its motion. So there's not a lot of information coming from the hip itself. However, when I come to the pelvis, and the musculature doesn't tell me much, when I come, a little bit more tightness in the lateral abductors, lateral glute medius and maximus. But when I test pelvic mobility, that's where we find the rigidity in the side glide that we demonstrated. And this is an oblique mobility. I'm pushing towards the right shoulder. I'm pushing away from the right shoulder. And that force translates through your pelvis. On this side, there's no oblique mobility at all. This is like a brick wall, much like the side glide. And when I try and spring it obliquely away from your left hip, there's just no mobility there at all. Now, your sacrum looks rather symmetrical in this position. I'm calling this pattern an oblique upslip. It's as though the ilium did climb obliquely. The right PSIS is superior, and it is also prominent posterior, as though it climbed up onto the sacrum. Otherwise, the sacrum is symmetrical throughout. And with this pattern, we would expect you to have some difference in the tone of the ligament. And if I test the left sacrotuberous ligament, that's right here. And if I test the right one is clearly softer. Can you feel that?
Yeah, amazing. Yeah, okay. Big difference.
Yeah, so I can get a lot more spring on that ligament. And I would expect the other ligament, the sacrospinous, would be taut. And this feels more like a rock.
Yeah.
And if I test this one right here, okay, that yields some. So it would make sense that if this ilium climbs up, that the ligament that connects sacrum to medial ischial tuberosity, called the sacrotuberous, would be relaxed. The one that goes almost obliquely would be taut, tighter, and that's what we find there. So if you would get up on your hands and knees, please. The point I want to make right now is that in this position, go ahead and sit back on your heels. In this position, your pelvis looks like there is a torsion of the sacrum. It's a very complex triplane motion and fixation. To simplify it, with a torsion you would be stuck in one quadrant with a PA spring, but every quadrant moves. So it's not about how something looks. This way of testing is about finding a significant difference in mobility, in which case we found the sacrotuberous ligament had greater excursion, it was softer. The sacrospinous was taut, and we found a lack of pelvic side glide to the left and a lack of oblique pelvic mobility. And even in this position, you can find that if you capture the PSIS, you can see that the body allows this force to go through it obliquely. And the same thing opposite on the right side just doesn't allow it. And you made a comment. It just doesn't give obliquely. You made a comment, something about it feeling like a concrete or something like that. What did you say?
I said one of my legs feels like I'm running on a regular springy leg, and the other just feels like I land on a concrete leg. It just, you land on it, it's like boom.
Yeah. Well, you know, the sacroiliac joint is a stabilizer and a force transducer and a shock absorber, and I would say that about the whole pelvic complex. The whole pelvis can move in three-dimensional space, and it can get stuck in strange ways, and this is a strange way, and it doesn't mean that it's inside your sacroiliac joint, but we can find specific points to test mobility where mobility is absent, and we can restore that movement, and we have no evidence that that really means that the restriction was inside the sacroiliac joint, but we feel pretty strongly that the restriction reduces mobility and shock absorption going through that joint. So I'm not hung up on the concept of calling this sacroiliac joint dysfunction. I'm more comfortable calling it a pelvic dysfunction that influences the hip. So to summarize, you're very rigid in pelvic side glide, you're very rigid in oblique mobility, and this causes inhibition of your hip flexors. Otherwise, the hip itself is fairly mobile, fairly similar to the other side. So we're going to treat it. We'll come back and refilm our results. Thank you.